All right. So, good morning, esteemed senior colleagues and colleagues. Well, welcome to another session of YOF webinar, which is an educational platform for us to discuss topics and issues in ophthalmology. And so today's topic is a topic that is that's important to not just the glaucoma experts and even ophthalmologists generally, but also it's a very important topic to the retina experts as well, and that's neovascular glaucoma. We have Dr. Adio Oluwatumayowa, who's a senior registrar at Eye Foundation Hospital, and he will be taking us through neovascular glaucoma. Please, we would appreciate if we can kindly mute ourselves so that we can have the meeting undisturbed. Thank you very much. So Dr. Adio Oluwatumayowa will be discussing neovascular glaucoma and its management with us in the next 40 to 45 minutes, and we'll take questions and comments after that. So Dr. Adio, you can please go ahead and start.
Thank you very much, Dr. Hello? Can you hear me well?
Yes, we can hear you well. We'll appreciate if you can speak louder into your mic so we can hear you more clearly.
All right. Thank you very much. My name is Dr. Adio. I'll be speaking on neovascular glaucoma. This is my outline. So by definition, I'll be defining glaucoma first. Glaucoma refers to a group of progressive optic neuropathies characterized by an excavated appearance of the optic disc, often described as cupped, together with loss of retinal ganglion cells and their axons, and corresponding vision loss. Intraocular pressure is a modifiable risk factor. Neovascular glaucoma is a severe form of secondary glaucoma, characterized by proliferation of fibrovascular tissue in the anterior chamber angle, and it can also be known as rhabdotic glaucoma, hemorrhagic glaucoma, thrombotic glaucoma, and congestive glaucoma. For the epidemiology, neovascular glaucoma is a rare pathology. Prevalence in the population, which only 0.01 to 0.12%. The incidence of neovascular glaucoma is 3.9% of all glaucoma cases, according to Havens et al., and 9 to 14.7% of all secondary glaucomas, according to Pandya et al. According to the recent global burden of disease study analysis in 2020, diabetic retinopathy was one of the main causes of neovascular glaucoma, and 33% of all neovascular glaucoma cases arise from central retinal vein occlusion, 33% from proliferative diabetic retinopathy, and 13% from ocular ischemic syndrome. A 5-year retrospective study done in University of Port Harcourt by Fieba et al. Shows a hospital prevalence of neovascular glaucoma of 0.3%, with retinal vein occlusion being the commonest at 53%, followed by proliferative diabetic retinopathy at 41% and uveitis at 6%. For the etiology, I broadly classify them into ocular vascular diseases, systemic vascular diseases, other ocular diseases, intraocular tumors, trauma, and ocular therapy. So for the ocular vascular diseases, proliferative diabetic retinopathy, ischemic central retinal vein occlusion, ocular ischemic syndrome, which are the most common. Then central retinal artery occlusion, branch retinal vein occlusion, sickle cell retinopathy, Coats disease, Hill's disease, retinopathy of prematurity, persistent fetal vasculature, anterior segment ischemia. For the systemic vascular diseases, carotid occlusive disease, carotid artery ligation, carotid cavernous fistula, giant cell arteritis, and Takayasu disease. Other ocular diseases like chronic uveitis, chronic retinal detachment, Stickler syndrome, endophthalmitis, and retinoschisis, and trauma also being a major cause. Ocular tumors such as uveal melanoma, metastatic carcinoma, retinoblastoma, lymphoma, and reticular cell sarcoma. So moving on to the pathogenesis. Neovascular glaucoma is mainly due to retinal ischemia, and the resultant retinal hypoxia leads to production of pro-angiogenic factors such as vascular endothelial growth factor, angiopoietin 2, insulin growth 1 factor, and inflammatory cytokines such as interleukin 6, endothelin 1, and nitric oxide to revascularize hypoxic areas. So these factors can then migrate anteriorly and cause aggressive iris neovascularization, which lead to progressive angle closure, elevated intraocular pressure, and glaucoma to optic atrophy. Why the lens and the vitreous act as mechanical barriers and also release some vasoinhibitory factors. So clinical pair will be that any complicated surgeries with posterior capsular rent or leaving the patient aphakic have more predisposition to iris neovascularization or anterior segment neovascularization as a whole. So this is a image, or at least a table showing just the brief flow chart of the pathogenesis. So usually there are pro-angiogenic factors and there are anti-angiogenic factors. Pro-angiogenic factors such as vascular endothelial growth factors, insulin-like growth factor, hepatocyte growth factor, basic fibroblast growth factor, platelet-derived growth factor, and the pro-inflammatory cytokines and angiopoietins. And the anti-angiogenic factors, the main one being the pigment epithelium-derived factor. So the VEGF increases vascular permeability, which will lead to leaky vessels. It will increase endothelial cell mitosis, which would form new vessels. Then also causes leukocyte adhesion to the endothelial cells, which leads to blood-retinal barrier breakdown. While the other pro-angiogenic factor, which I mean, promote new vessel growth and proliferation. So it's almost like a tug of war between the pro-angiogenic factors and anti-angiogenic factors. And the pro-angiogenic factors overwhelm the anti-angiogenic factors and lead to vessels new formation of the vessels and blood retinal barrier breakdown. And then this now also affects the minor and major arterial circle in the iris. So these capillaries are there is neovascularization and of the iris and neovascularization of the angle in the arterial segment. The formation of the fibrobascular membrane, which leads to trabecular meshwork obstruction, causing intraocular pressure rise in the open angle stage. Then contraction of this fibrobascular membrane leads to peripheral anterior synechial formation in the angle closure stage. So neovascular glaucoma occurs in 3 phases. There's a preliminary phase, which is the pre-rebosis phase, in which you see the clinical findings of the underlying cause of retinal ischemia, whether it is central retinal vein occlusion, proliferative diabetic retinopathy, or the ocular ischemic syndrome, or any of the other conditions that lead to retinal ischemia. Then the first phase is the rebotic phase, which there is the iris neovascularization at the pupillary margin. There is, in this case, there is normal intraocular pressure and there is no sign of glaucoma. For the second phase, the secondary open angle glaucoma, in which there is neovascularization of the iris stroma and the angle with a fibrobascular membrane over the trabecular meshwork. In this case, there is raised intraocular pressure due to the fibrobascular meshwork occluding the trabecular meshwork and impeding outflow. Secondary closed angle glaucoma is the third phase, and it's characterized by contraction of the fibrobascular membrane, leading to formation of peripheral anterior synechial and resultant angle closure. So in these cases, you see very high intraocular pressure, up to 40 to 60 millimeters of mercury, iris changes such as ectropion UVA, pupillary dilation, or mid dilation. Something to note is that the new vessels, when you see them, they are very irregular, thin, weak, and they cross the scleral spur as opposed to normal vessels. The ectropion UVA is often observed when altered vessels and contracting fibrobascular membrane pull the pupillary margin, causing movement of the iris pigment epithelium, which is posterior, and that moves forward to the anterior portion of the iris. So the first image Um, the first image is showing the phase one, the rebiotic phase, in which we are seeing the peripapillary vessels, neovascular vessels. Then the second image is showing that these vessels have progressed onto the stroma past the papillary region. Then the third image is showing new vessels in the angle itself, the secunoscopic image. Also, there's the waist grading of the anterior chamber and iris and anterior chamber angle neovascularization. Four grades for each that's NVI and NVA. So for the NVI, meant to be NVI, iris new vessels are located at the papillary zone, less than 2 quadrants. For the grade, iris new vessels are seen at the papillary zone, greater than 2 quadrants. For grade 3, iris new vessels located at the ciliary zone, or you see an ectropion UV in 1 to 3 quadrants. Then for grade 4, surface new vessels at the ciliary zone or ectropion UV greater than 3 quadrants. For neovascularization of the angle, you see angle vessels cross the scleral spur and they ramify or offshoots onto the trabecular meshwork, but it's in less than 2 quadrants. And angle vessels cross scleral spur and ramify on the trabecular meshwork greater than 2 quadrants. The angle vessels for grade 3 are at the trabecular meshwork itself, and there is peripheral anterior synechia seen in 1 to 3 quadrants. And in grade 4, peripheral anterior synechia is in greater than 3 quadrants. So for clinical features, symptoms include pain, which may vary from severe, or the patient might present with no pain. They might just be in the rebiotic phase. Decreased vision, the complaint of decreased vision, redness of the eye, tearing, photophobia, nausea and vomiting due to the in the closed angle stage. For the signs, there'll be reduced visual acuity, could be reduced visual acuity, ciliary injection, corneal edema, anterior chamber reaction, it could be hyphema, a fixed dilated pupil, could be neovascularization of the iris or of the angle, and raised intraocular pressure. So moving on to management of neovascular glaucoma, starting with the history. It can occur at any age, but it's more likely to occur in older age, greater than 60 years old, due to the most of the risk factors that we see in these patients. Gender is more likely in males. Complaints and history presenting complaints, they'll complain of decreased vision, like I already mentioned in the clinical features. And they might state pain, redness, photophobia. Vascular history. In the vascular history, there will be history of ocular trauma, history of intraocular surgery. There could be history of ocular trauma, history of intraocular surgery, history of primary open angle glaucoma, which can predispose to central retinal vein occlusion. Past medical history, history of uncontrolled diabetes, uncontrolled systemic hypertension, obstructive sleep apnea, sickle cell disease. For drug history, there could be histories of antihypertensive medications, anti-glaucoma medications, histories of statins, oral hypoglycemic agents or insulin, oral contraceptive pills. Social history is a history of smoking, alcohol intake. Physical examination, want to do a general examination, examination of cardiovascular, which there could be normal, elevated, or low blood pressure, and other systems also. For ocular examination, doing the visual acuity most times will be decreased when the patient presents, especially in our region. Lids and anexa will be normal except in the setting of trauma. Conjunctiva could be injected or transparent, depends on ciliary flush. The cornea could be hazy due to corneal epithelial edema. Bullae could be clear, or there could be endothelial blood stain in the setting of an hyphema. Intraocular pressure could be elevated, normal, or there could be hypotony in very advanced stages when you've already done a lot of interventions. Anterior chamber, there could be hyphema, could be flare. Anterior chamber could be deep, could be shallow, quiet, or it could be flat. Iris could look normal in the pre-uveitic phase, or there could be neovascularization of the iris surface effacement, which you see most times in the very advanced stages after ectropion UV has occurred. Iris atrophy, it could also be posterior synechia or peripheral anterior synechia. In the pupil, could be sluggishly reactive, relative average pupillary defect could be present, could be mid-dilated, non-reactive, or you see the vessels on pupillary margin. On gonioscopy, there could be an open angle, and there could be angle neovascularization, the fibrovascular membrane, peripheral anterior synechia, closed angle. There could be blood in the anterior and the anterior chamber angle. The lens could be clear, there could be cataract, there could be the patient could be pseudophakic or aphakic. The vitreous, there could be no view of the vitreous due to the cataract or the vitreous hemorrhage. There could be hazy vitreous, syneresis. The vitreous could be detached, or there could be silicone oil if there has been a previous intraocular surgery, or there could be air in the vitreous also due to previous intraocular surgery. The retina, you could see dilated vessels, tortuous and engorged vessels in the setting of a central retinal vein occlusion, new vessels in any of the ocular vascular diseases could be present, macular edema, hemorrhages, flame hemorrhages, and dot and plug hemorrhages, disc edema. Then also glaucomatous disc cupping could most likely will be noted. Retinal detachment, like I mentioned, as one of the causes, especially if it's chronic retinal choroiditis, retinoschisis, and there could be a retinal tumor. There could also be signs of a choroidal melanoma or features of metastatic cancer. For the investigations, I classify them into ocular investigations and systemic investigations. For the ocular investigations, we can do an anterior segments optical coherence tomography to see the state of the angle itself, and it can give us an image of the angle and how open or closed it is. Although gonioscopy is a gold standard, angiography can also be done to see to visualize the new vessels and see which of them are leaky exactly. Fundus fluorescein angiography also could be done, especially when you are trying to decide which of the ocular vascular diseases is the causative factor. So with the fundus fluorescein angiography, you can see the non-perfused areas and also the new vessels that are seen, and also the hemorrhage, the vessels that are leaking and causing hemorrhage. The iris fluorescein angiography also is something that can be done. Posterior segment OCT and angiography and electroretinogram also be done. Systemic investigations will include fasting blood sugar, glycated hemoglobin for diabetic patients, fasting lipid profile, electrolyte urea creatinine, full blood counts, erythrocytes, sedimentation rate, C-reactive protein, antinuclear antibody, the carotid Doppler for the ocular ischemic syndrome, temporal artery biopsy, a CT, MRI scan, computed tomography or magnetic resonance imaging scan, and angiography can also be done for patients with carotid disease or occlusions. The visual diagnosis will include acute angle closure glaucoma, uveitic glaucoma, iridocorneal endothelial syndrome, Fuchs heterochromic iridocyclitis. So on to the management, the treatment itself. The goals of treatments include number one, identifying and treating the underlying cause of retinal ischemia. Number two, management of the intraocular pressure. So the treatment, we first have to start with counseling, because neovascular glaucoma, especially in the late stages, has a very poor prognosis. So you really want to counsel the patient on the diagnosis and the prognosis. You want them to know what to expect following your treatment, and depending on what state they present at, you want them to temper their expectations on vision recovery. Treatment of underlying systemic disease is very important, and this first entails referral to the physician for control of diabetes, systemic hypertension, and management of any of the causative systemic vascular diseases. So the treatment strategy, starting with the early robotic phase, it depends on the stage of glaucomatous damage, really. For the early robotic phase, when the neovascular NVI first develops, retinal ischemia reducing treatments such as unretinal, photocoagulation, and anti-VEGF usually used, because studies have shown that this would regress the vessels that have grown forward to the anterior segments, and in turn also reduce the occlusion, and also the intraocular pressure can also be reduced in that way. But in stage 2 and 3 of neovascular glaucoma, where there is already open angle glaucoma and also closed angle glaucoma, the treatment is not just by PRP and anti-VEGF. You have to also employ pharmacological treatment, both local and systemic if necessary, and eventually surgical intervention. This is due to the fact that duration of the NVI suppression by the anti-VEGF lasts mostly just about 3 to 6 weeks. So it's mostly used as an adjunct to either surgical or laser therapy. This was proven by Wakabayashi et al., Zhao et al., and Kang et al. So you can use it as an adjunct to either the any of the therapies that I will mention following up. Then also the central vein occlusion study recommended that for ischemic CRVO with NVI or NVA, you want to do a PRP, then 2-weekly follow-up. Then afterwards, you do a supplemental PRP if necessary. But if there is no NVI or NVA, you can just continue following up unless there is poor compliance. Then you cannot do a PRP. Follow-up in CRVO is mostly for the first 6 months. So for the medical treatments, it entails use of ocular hypotensives, aqueous suppressants such as beta blockers, alpha agonists, carbonic anhydrase inhibitors. You want to avoid miotics in these patients, and acetazolamide should be used with caution in diabetics and also patients with renal disease. Cycloplegics can be used to resist synovial formation, and topical steroids for the inflammation that will ensue, especially in the acute phase. Medical treatment is mostly useful only in the open angle stage, and is not effective when synovial angle closure occurs. So it's mostly a temporizing measure before you eventually have to go for the surgical treatment. And the indication for surgical treatment is number 1, good visual acuity. When the patient first presents, you see that they have good visual acuity despite open angle glaucoma stage. So you want to quickly go ahead for the surgical treatment straight ahead. Then insufficient maximal pharmacological control of the intraocular pressure, which occurs in over half of the patients. Then disease progression is observed. That means despite your treatment, you see that the patient still progresses to stage 3 with synovial angle closure. You want to quickly go ahead for the surgical treatment. So the first surgical treatments start with the filtering surgeries and trabeculectomy, not just trabeculectomy, but with antimetabolites. Usually, trabeculectomy has historically been associated with a high failure rate in treatment of MVG, mostly due to the fact that there is a lot of scarring in this case, also high intraop bleeding due to the fact that those vessels are in the anterior segments, and also just increased rates of failure due to fibrotic reaction. But in combination with antimetabolites, success rate has improved. Studies have reported a success rate of 62%, increasing to 81% compared to normal trabeculectomy at the end of 1 year, when they compared trabeculectomy versus trabeculectomy with automatic C. And this was done in patients with some MVG secondary PDR. So trabeculectomy plus antimetabolitis is one of the best ways to manage intraocular pressure. But even better than that is the glaucoma training device, which is indicated if trabeculectomy fails or if there's a risk of, or is a high risk of failure because of the scarring and the inflammation of the conjunctiva. So valve implants have been shown to be more effective. Valve implants like Ahmed valve have been shown to be more effective than non-valve implants, such as the Bevet and the Molteno implants, and they have lesser chances of hypotony and iris damage, according to Saint et al. And also a preoperative intravitreal bevacizumab injection before filtering surgeries has been shown to improve surgical outcomes and reduce the postoperative risk of hyphema, according to Saito et al. Another surgical treatment is past planar vitrectomy plus endolaser photocoagulation, and this is done in the presence of cloudy media. You do not, the surgeon cannot see enough to do a pararetinal photocoagulation, so it's best to just do a vitrectomy to clear the media, then also an endolaser photocoagulation. And also this can also reduce VEGF flow that is floating in the vitreous. Then moving on to cyclodestructive procedures. This is indicated in cases refractory to medical and surgical treatment and eyes with low visual potential. So the most frequently used procedures are transscleral cyclophotocoagulation and endoscopic cyclophotocoagulation. And sometimes, since neovascular glaucoma is often resistant to any treatment, and most times it just progresses, it can often lead to blindness and unbearable eye pain. And in these cases, enucleation should be considered. But this is the end stage. And complications of neovascular glaucoma can be corneal decompensation, loss of vision, like I mentioned in the previous slide, a painful blind eye, in which case you can give a retrobulbar alcohol injection or you can do enucleation. And a phthisis bulbi can also occur due to hypotony and also from frequent cyclophotocoagulation. In conclusion, neovascular glaucoma is a potentially blinding condition with challenges in control of intraocular pressure and preservation of vision. Early detection and attention to etiological factors with timely institution of the appropriate mode of treatment may help in preservation of features. These are my references. Thank you very much.
Thank you very much, Dr. Adio, for the presentation. So we'll take questions and comments, and we'll also appreciate senior colleagues in the house to also give comments and additions to for us to all benefit and learn.
Thank you very much for your presentation. Can I go ahead and ask? Okay, yeah. Thank you very much. In your etiology, you mentioned trauma as one of the etiologies. I would want you to explain how trauma could lead to neovascular glaucoma. And also in medical treatment, you said miotics should be avoided. What is the reason why we should avoid miotics in the treatment? And then finally, when you talked about giving retrobulbar alcohol, is it a one-off treatment or is it usually continuous? Like when you give that retrobulbar alcohol, does it take care of the pain forever, or we have to keep on giving that treatment? Thank you.
Good morning, sir.
Good morning, sir.
Thanks for the presentation. I'm Dr. Gabriel. During the West classification, I saw NVA. I don't know whether the first rule meant neovascularization of the iris, where you have neovascularization of the angle, neovascularization of the goggle. Maybe that was an oversight. And also, I just have a little contribution. Patients who have had cataract surgery, It stated that they are more prone to complications, of neovascular glaucoma, because it stated that the lens has a protective mechanism, for preventing those agents that you talk about, like the VEGs and other things, for causing neovascularization of the iris and neovascularization of the angle. So a patient who has had cataract surgery, has a greater risk, of those complications than a patient who has not had cataract surgery. I just wanted to bring that up. Thank you.
Thank you very much.
Did
Yes, I meant MVI and MVA.
Okay, all right.
Sorry about that.
Dr. Adio, do you want to go ahead and answer the first comments and questions we got?
Okay, no problem. So about the, okay, I've answered the MV. I'm also looking through the chat if there's any other question. All right, so the first question was about the myotics, right? So in the presence of the synechial stage of the neovascular glaucoma, you want to avoid myotics because first of all, they're not so effective, and also you are going to be pulling on the vessels that are located in the anterior chamber angle, and you could cause bleeding and hyphema, and that will be counterproductive to your treatment. So that's the main reason why you want to avoid myotics. So the second question was asking about the purpose of, I think the reason why trauma causes neovascular glaucoma. So in the setting of trauma, when there's trauma to the eye, there could also be the retinal hyperperfusion due to the Berlin's edema and all of those. And following that, there could be some neovascularization, or there could be some abnormal vessels that could be formed, and this eventually can cause your neovascular glaucoma, or there could be retinal detachments which could become chronic and then now lead to the formation of new vessels and then neovascular glaucoma. So trauma as a whole, ocular trauma as a whole, generally, either anterior segment trauma, posterior segment trauma, and the formation of the vessels that can form following that would also lead to neovascular glaucoma in that way. I don't know if I answered the question or. Then I think the last question was asking about purpose of electroretinogram. So the electroretinogram will show due to retinal ischemia, there will be reduced function of the retina itself. And you will see this in the readings of the A, B, C wave. So when you do an electroretinogram, you would see that, okay, there is reduced amplitude of, mostly all the waves actually would be reduced in amplitude. And this way you can confirm that, fine, there is retinal ischemia. And we know that the function, when there's retinal ischemia, that there will be reduced function of the photoreceptors, bipolar cells, and all of that. So that's the purpose of the electroretinogram in this case. Thank you very much.
Okay, thank you. There was also a question about the retrobulbar alcohol.
Yes. Yes, it can be repeated. Yes, it can be repeated because it can be repeated about 3 times, but the major reason why it has been phased out is because it leads to hypotony the more you give it. So it can be repeated about 3 times according to what I've seen in different literature, but usually Adio, the more you repeat. So some people just tend to go for enucleation when there's a painful blind eye.
All right, thank you very much. So there's a question here also about why neovascular glaucoma is more common, more likely to occur in male gender and female.
So I didn't really see any specific reason, but if I'm going to make an educated derivation from that, it's going to be due to the risk factors themselves. So if we're looking at the risk factors that can cause vascular diseases, then we can just maybe that's most likely why it's more likely to occur in male gender than in female gender. But there wasn't any specific reason. I got that information from a study, which I can also provide, and is in my references. But
Okay, thank you very much. So I think so just an addition on the question about the role of ERG in evaluating a patient with neovascular glaucoma. So, the retinovascular causes actually they they are actually one of the reasons why you do ERG, and that's because we see a negative ERG pattern because of the inner retina ischemia. So it's more or less trying to identify the etiology, and most when you see negative ERG pattern, you suspect an inner retinal problem, and most likely due to most of the retinovascular disorders that was mentioned in the slide. Um, so do we have more comments also? Um, I also want to use this opportunity to appreciate the presence of Professor Adio on this meeting. Thank you very much, Mark, for making time to join. I think she was on before.